Testing 1, 2, 3. Okay. Good evening, everyone. Let's go ahead and call our Human Resource Committee together. And it's great seeing you. It's been a long time since we had an HR meeting, so I'm looking for a lively, energetic little group today. Okay.
We're small, but we're mighty.
We are ready. We are ready. Okay, we do not have any citizens wishing to address the committee, so we will have approval of our minutes. So did you have a chance to read the minutes?
Motion to approve.
All right.
I'll second.
Okay. There's been motion and second. All those in favor signify by saying aye.
Aye.
Those opposed by nay. Motion passes. Okay. Well, Ashley, you are up.
To the committee members, Madam Chair. I'm so glad to be back before you. It seems like it's just been a long time since I've had the opportunity to report on all of the things that have been happening in HR and how we close out the fiscal year. As always, I like to start by really centering us in kind of why we're here. We know that often I come here and I talk about initiatives, I talk about metrics, but ultimately the reason why we're here is to make sure that the folks at JPS are supported and that we have all the things that we need to have an engaged and best-in-class workforce, and grateful to the committee for all that they do to empower that. So we want to highlight a couple of what I call HR in action, strategic updates that really give you an opportunity to see some of the things that we're doing for the employees. So we had the opportunity to stand up a new program called The Crew, Celebrating and Recognizing Employees' Work. It's an annual membership of 100 employees across all of our departments, both full-time, part-time, and from individual contributors all the way up to executives that really engage in extending the hands of engagement here at JPS. And so the purpose of the crew is to increase recognition within the organization and propel the mission of JPS Health Network. And ultimately, we're also using it as a development vehicle. And so these are among our most engaged employees. They were either nominated by their peers or self-nominated. They were approved by their leaders, but they have the opportunity to both be ambassadors for JPS and also have the opportunities for some special development opportunities and learning that really does prepare them as emerging leaders within the organization. We recognize that doing good work is really not enough. You have to do good work and be engaging. And so as we think about succession planning and some of the other strategic imperatives we have before us, this is another way that we're really getting the next generation of leadership at JPS ready to step up. Now I'd like to really bring home, we often talk about engagement as a kind of broad and nebulous thing. We come in here every year and we report to you on our engagement numbers and our Gallup numbers, and often we don't get an opportunity to actually kind of contextualize and ground in what those things really mean. I know last year we talked a lot about our Q10, so that's our best friend at work. And we don't often talk about how that really does matter in real life, and so I'd like to highlight some real live JPS Q10s, 3 of our nurses who are friends both at work and outside of work, who had the opportunity to do something exceptional back in October. So Kakita Edwards.
Ashley, do they know what Q10 is?
Q10 is your best friend at work.
Okay.
So your
That's the question
Q10 is
I
your
had.
best friend at work. So on October 16th, these ladies were at Shaw's Burgers on Magnolia. They were there for open mic night, and they were listening to Tommy Luke, who is a local musician who was playing there. And right after he finished his first set, he had a seizure for the first time. He went into a critical health incident, and these 3 ladies jumped to action, stabilized him, and saved his life. And so when we talk about the power of connection at work, it really extends beyond JPS into the community. And because we're fostering friendship and engagement at work, these ladies took that beyond the 4 walls of JPS and were able to make impact in the community that Tommy Luke and the patrons and folks at Shaw will never forget. So I wanted to highlight this story as a real tangible example of the power of engagement at work. And I also have these ladies here today, and I'd like them to stand and come on up and introduce themselves. quickly, because I think it's good for the HR committee to see the impact that our folks are making in the communities. Don't cry. Well, just quickly introduce yourself, tell us what you do here at JPS, and maybe give us just one or two sentences about kind of what engagement has meant to you and how really it impacted your ability to do something really cool in the community.
I'm Kakita Edwards. I'm the manager of Trinity Springs North, LCA, Local Commitment Alternative, right off of St. Louis, which is a part of Trinity Springs Pavilion. And so we have patients, our patients there are involuntary, of course. And so since joining, December 2nd will be my 5th year here at JPS. And so these young ladies knew each other prior, and when I came on board, they kind of onboarded me as well. I don't meet strangers. And so even before trying to formulate and help our teams understand what Q10 was, we were talking about amongst ourselves about just being Q10s. And so from there, we do things inside and outside. We celebrate each other, families. We've supported each other on so many levels, personal levels, and during times of crisis as well. And so it doesn't stop. And so we happen to be at Shaw's, one of our favorite places to listen to local music and entertainment, and that's where we met Tommy previously. And so it was just us moving instinctually to do that. And so it has helped us. I mean, just to say, with this second year, my team has 100% completion of the employee engagement survey. And so it became a big competition in behavioral health, because last year I was the first unit to do that. And so we've now just everybody is, we can say, I can honestly say probably that all of us, all of the managers over there are Q10s. And so that's what engagement has done for us.
All right.
I'll go next. I'm not so much of an impromptu person, but it's okay. I just rise to the occasion, as you can see. So my name is Melanie Lacey. I'm the manager of house operations for behavioral health. So I like to say the umbrella unit. So anyone that does not report to a home unit reports to me. So I have over 100 direct reports, and I do have my own leadership team. My mission is to uphold the organization's missions, not only because I value them because it's a place that I work, but I hold them because that's who I am as a person. So I'm happy to help and assist the community, both inside work and outside of work. I'm always happy to do what I need to do. One of my quotes was, "It takes a village of caring individuals to create love and foster those healthy relationships." So I'm always happy to support, provide care, and help to do anything that I can. So I appreciate you guys highlighting us. I appreciate the opportunity. I don't consider myself a hero. I'm just a person that do what needs to be done. Thank you.
And one hell of an impromptu speaker.
Thank you.
So my name is Salofin Jutu. I'm one of the managers in in TSP. I'm manager at 2 Northwest. 2 Northwest is a high acuity unit. That's the highest acuity unit after PEC, and I love taking care of those folks. So I've been here for over 8 years. I onboarded her, just like we onboarded. So I onboarded her. So the Q10 theory started a long time ago. Amongst 3 of us, we're actually all the managers in TSP are Q10s. Right. And for us to relate the Q10 vision to our staff, we have to be Q10. And just like Melanie said, we are not heroes. I just seek joy in what I do, and I was at the right time, right place at the right time, and I'm glad to be part of the team that rescued the guy.
Thank you.
Well, thank you. Although you say you don't want to be a hero, you are our heroes, okay? So thank you for all you do.
Thank you, ladies.
Great.
So I think, again, as we talk about, I'm going to start going into the metrics, but when we talk about engagement, that's what it really looks like. It's more than the metric. It's a feeling. It is commitment to each other, and I really appreciate that team for coming and sharing, but for saying that in order to have engaged culture at work, we've got to model that. So they're not just telling their staff, they're modeling that behavior. So I believe the communications department has already posted it on LinkedIn. So it's posted, yep. So I wanted to just share with you, typically this time of year, we share our accomplishments for fiscal year '24, and so I created a snapshot of not just accomplishments, but opportunities. I've been in this role now about a year and a half, and I think, Dr. Duncan and I have talked about it, and it probably took me about 6 to 9 months to just figure out what needed to be worked on. And it's been a journey and quite a bit, but I'm really proud of the work we've done so far and keeping my eye on the work we have ahead of us. So over the last year, we really did focus on voluntary turnover under 1 year, and we had a 7.5% increase. So that's over 200 basis points, not increase, Lord Jesus, decrease, decrease in voluntary turnover under 1 year. We started tracking vacancy rate for nurses this year. And so the national average is about 9.9%, and we're sitting at 6.8%, which is 3.1% below the national average. And we're really proud of our ability to attract and retain nurses here at JPS. On a more personal note, I was really challenged by the fact when I took the helm of leadership at JPS that the Human Resources Department's engagement score was not great. We had an opportunity to really reaffirm trust within that department, and I feel like my mother would often says your first ministry is at home. And so for me, it was really important to see those scores in the HR department increase, and I'm proud to say that we had a 0.29% increase this year, which was significant. We 4.43%, overall, and so we will continue to work on that, but I'm really proud of the work we did in our own house to be the models of engagement. We really increased volunteer services. We set a goal of having 6,100 hours, volunteer hours across the network. This year, we ended with 8,731 hours, which is about a 40% increase. We launched an automated HR analytics dashboard, which is why we're able to report these things to you today. So now those at the executive director level and up can see their analytics real time. And we are working on a V2 that would take those analytics down to the manager level. We had a goal for 70. So it's a HR analytics dashboard. It's a Power BI. So it's Power BI. But we did not have a place that had all the metrics in one place. We also hadn't anchored to best practice, so now they're anchored to the Saratoga benchmarks. Those benchmarks are built into the dashboard, so it is fully functional. It is a single source, and people can trust the data to know that it is anchored to best practice. So we're really proud of it. We set a goal to have 3 engagement master classes and have 75% of our leaders participate, and we exceeded that goal this year. So we are continuing to work to get our leaders ready to lead into the next generation. The other thing that I'd like to highlight quickly is around benefits enrollment. So we've really been assessing how employees can get the best value while ensuring that we manage benefits costs for their network. On average, benefits overall increased between 9 to 12% year over year. And so in identifying opportunities, we saw an opportunity for employees to make shifts as appropriate from the EPO plan to the high deductible plan with some support. So we did a couple of things. We put some smart technology in our open enrollment dashboard that allowed people to put in the actual scenarios of their life, how many children they have, how many injuries they have in a year, how often they see a specialist, and then give them a recommendation for the plan that was both best and most efficient for them. And through that, and one other initiative where we give those who choose the high deductible plan automatically $250 in their HSA, and the opportunity with participation in our Enliven Wellness events to get up to $500 a year in their HSA. And so through those efforts, we've seen a 3 or 4% increase in those who've elected the high deductible plan. That's cost savings to the network and also right-sizing the coverage for families so that they are getting the best value. And so I won't go any further into the highlights. I would like to spend just a moment on opportunities as an area of focus next year. We still have quite a bit of opportunity around HR technology and analytics. I said when I first came here in 1996, called and they wanted their HR tech back. And so I'm proud to say that 2002 we've eclipsed 2002. And so with the implementation of M4, we'll be rolling into 2024, 2025, but we still have a good long ways to go, and we'll be focusing on that this year. We also have opportunity around workforce optimization. We have the opportunity to stand up a labor council and to think more strategically about how we invest in the right mix of talent, how we're upskilling our talent to make sure that we are getting not only the right number of FTEs, but the right folks in the right seats. So we're going to do quite a bit of work around that this year. We're continuing to double down on performance management and succession planning because, quite frankly, it is the way we're able to get talent mobility galvanized at JPS and ensure that we have the ability to promote from within. HR ops and employee relations. We are in a different time. Employee preference is changing, what employees expect, how they engage when they're unhappy about something is changing. And so we have to continue to upskill our staff, upskill our leaders to make sure that we're meeting employees where they are and they have the tools that they need to manage the workforce. And then last but certainly not least, I rated ourselves as 4-star with employee engagement because we are never, ever going to reach the pinnacle there. It is an ongoing journey that we won't ever take our eye off of. So this is just a snapshot of the things we've accomplished this year. We've worked really hard and the things we're going to continue to focus on going forward in fiscal year 25. But we thought it was appropriate to share with you all of the hard work that the team has done this year. Any questions?
Yeah, I have a question on the HR operation and employee relation. Key initiative, HR University, what are we
So
talking
we
about?
are standing up training for both HR business partners and leaders on how to manage everyday HR things. So think about, the average frontline manager and how they manage somebody who's on leave, FMLA, how to understand how to navigate that. Making sure that the HR business partners have a strong ability to do investigations and do them objectively. Helping leaders how to understand when they should document performance issues and how to manage somebody through performance. So just building that kind of HR 101 skill set.
Okay, all right, thank you.
Ma'am. Any additional questions? So I just want to get that those strategic priorities out in front of you. You all saw these when we did our budget retreat, but this really just kind of highlights the areas of focus for this year, and it aligns with those opportunities as well. Then going into HR metrics, as promised, we're going to share with you a little bit about our engagement survey findings. As you all know, we performed really well on our engagement survey. We're really proud of the work that happened over last year. We had 95% participation among our employees, and we scored at a 4.32% this year, which took us into the 97th percentile among hospitals and healthcare social assistance hospitals. We really did double down on making sure that engagement was embedded in ways of working. We continue to tailor our training, our leadership development training, to anchor to our Q12, so the 12 questions that really do drive engagement, and it's worked. When you hear leaders and people talking about Q10 and Q12 and Q14, it means that it's common language. It's the way we operate, and that is where I think we continue to see gains in both participation and our scoring. We opened a new opportunity this year by pulsing our part-time and PRN staff. So for the first time, our part-time and PRN staff had the opportunity to share their voice, and 77% of them took the advantage to be able to speak about the things that they felt like were going great at JPS and the things we needed to improve on. And we saw 4.25 as the first time score for that. So they sit in the 93rd percentile, which means we do a great job of not only engaging our full-time staff, we do a great job of making sure we're meeting our part-time and PRN staff where they are and in making them feel included in our workforce as a whole. So last but certainly not least, we have done a ton of work this year around clinician engagement, and I really do have to pause and shout out Dr. Carla Pudi and Dr. Alawi for the work that they have done in leading the organization and really listening to our clinicians differently. We know that the things that engage clinicians are not necessarily the same thing that engage employees, and so we did a lot of active listening this year. We had 85% of our clinicians respond. Just for context, the national average sits around 60%. Gallup was so impressed with our response alone that they really have asked us to kind of delve into more closely what we've done to engage our clinicians and our, providers to really lift their voice up. They earned a 4.13, which was a significant increase from last year. And again, they are sitting, in the 80th percentile, the 82nd percentile, which is really, really significant for our clinicians. And more than that, I think the feeling again is palpable. You can feel that the clinician population is feeling like they're heard, feeling like that we are listening actively, and we are working to improve in areas where they've lifted concerns. So we're really proud of that work. When you look at our overall engagement ratio, we are highly engaged. Our opportunities continue to be around, those folks who I call their meh in the yellow, right? They're not in love, they're not highly engaged, and they're not actively disengaged. That's our greatest opportunity, but I will tell you, we are nearly at the top of the pinnacle for where we can be in healthcare, for what's reasonable. We are never going to take our foot off the gas. We are going to continue to press forward, but really we are pivoting our focus from improving our scores in certain areas to maintaining and, again, building ways of working.
Ashley, just remind me, I know we were on the phone with Gallup, but what percentage of the population are just actively disengaged in life? Because this was an interesting, I thought, metric, that there is a certain percentage of the population. So you're not going to ever get below that number.
That is correct. On average, 5. So 5% of the population is just grumpy. They're just Scrooges. That's how God made them, and they will always be among us. So, what Gallup has really, encouraged us to do is not to focus on that small 6%. You still want to touch them, right? But to really focus on the 29% and to focus on maintaining engagement where people are actively engaged. Because what we know is that engagement is fragile. It is a feeling, it is hope. And that's really what engagement is, a measure of hope that people will meet them where they are, hope that the work environment will continue to be one that people feel like they can come to and be authentic and do good and meaningful work. But it is fragile, and change can be disruptive. And so we really have worked to make sure that we are navigating change appropriately, that we're communicating with our employees, and that we are providing and empowering leaders with tools so that we all can own the experience and the environment here at JPS.
I have a question on, when I look at the clinicians' engagement,
Yes.
it's a large indifference. Then I go over to the engaged employees and they're not engaged. So what's the difference here?
So when you look at the clinician engagement, keep in mind their score is 4.13, so a little lower, right? It's not quite where ours is. You've got 24% that are like full 9 and 10s, right? Top. And then 64% are in the middle. So they're not disengaged at all, but they're not fully engaged. So our opportunity really does sit with that 64%. How do we get them moving to being fully engaged? And so it's a continuum and a journey, whereas you see in the HR or the employee space, we are at the 97th percentile. So we have to, by virtue of being there, we have to have more people who are like actively fully engaged or in the green, right? And often they use this term indifferent, which I don't love, because I think it's really a misnomer. There are many people who are actively or who are engaged at work. They enjoy the work they do, but they're not cheerleaders, right? They are not the ambassadors. We have among our employees, go back.
Okay. So while Ashley's trying to find that, I think what we heard, and maybe Dr. Carla Putti, you could probably give some clarification on this, that it is a word that has a negative connotation when you first look at it, like you've got 60-some% of your doctors indifferent, but it does not really speak to the engagement level of that 60%. Dr. Carla Putti, I know this question came up at the...
Yes, and
Okay. Yeah.
thank you, Dr. Duncan. Yes, I had the same response and asked the same question. I think think maybe next year Gallup will find a better term for that phrase. It is not reflective of the connection our clinicians feel. I think the way they decide that is a composite of people who have said top, 5, 5, 5, but even if they answer 1, 4, then it looks like they're not all in, but they could be answering, I'm just there. So it is, we have more work to do on the clinicians, and we have to make that better. So, but yeah, it doesn't reflect truly the word indifferent.
Okay, all right.
I would say, when you see folks in green, you think about super fans, like the person at the football game with the pom-poms and the finger and those in the yellow are often fans and cheerleaders, right? They came with their sweatshirt on, they're at the game, they're cheering, but they're not super fans. And so that's where the opportunity is to kind of move them into that super fan kind of space. But it does not mean that those folks who just came with their sweatshirt, bought their ticket, and are actively engaged in the game are not, still engaged and contributing to engagement here at JPS.
Okay.
It's like Blake wears that GPS pen. Yeah, he is the green.
That's right. I am definitely engaged. And back to Ashley's sports a metaphor. The disengaged should be like the lady that sits next to me at the TCU football games, mainly to support her husband, but she brings her, I don't know if it's a Kindle or an Amazon book reader, and she reads novels, throughout the game.
Right.
That would be disengaged.
That is correct. That is correct. Absolutely. You're spot on.
All right.
So I won't spend much more time on this, but I did want to share the trend over the last couple of years. When you start to look at the engagement distribution curve, it really does speak to the fact that we are making the right kind of progress. I say it all the time, good, better, best. Never let it rest until your good is better and your better is best. And this shows that we are pursuing progress and not perfection, that we're on the journey, but we are doing the right things. And I'm so proud of the team. I'm grateful to Dr. Duncan for allowing us to continue to focus and invest on engagement, and grateful to the HR committee because the work and the investment that we're putting in really is paying off, and it makes a palpable difference in our work environment and among our employees.
Okay.
If I can just make one comment, because as the board talks about being more financial sustainable and continuing to do well financially and prepared for the future, it is these kind of investments. You heard at the quality meeting, I think, Dorothy, I know that you were there, that we also, during the time of survey, take what's called the culture of safety survey, and we are seeing improvement in that in the organization. So those investments that the board allows us to make in our employees, in the quality of the work we do, and you'll hear today around patient experience, because I think there's still opportunity to connect the patients with the organization's movement forward. Those do translate into better financial for organizations. So organizations that have not invested struggle with their bottom line. So this does have an ROI for the organization. So I just want to.
All right.
Absolutely. I echo that sentiment. And Dr. Duncan, we talk about it frequently. When you have engaged teams, they are more diligent. They are going to be communicating more collaboratively. They have the opportunity to increase patient safety. Innovation flourishes in highly engaged environments because people are working collaboratively and thinking outside of the box where there's psychological safety. And last but certainly not least, happy employees don't sue, or they sue less, right? And so all of those things really do result in tangible cost savings to the organization. And then we'll talk a little bit later about turnover, but the bottom line is there's a real cost to turnover, and we've done quite a bit to reduce it as well. All right, quickly, I'll go through our Tier 2 goals. We brought this to you early in the year. We decided beyond the AIP goals to focus on 3 areas, and that were resident retention. So we set a goal to retain, following training years, 11% of our residents, and so we ended the year at 13.01%. We set a goal to increase physician engagement mean score with a stretch goal of 3.93%, and we ended the year at 4.13%. And then we set a goal for 5% reduction in voluntary turnover under 1 year, and the stretch for that was 27.37%, and we ended the year at 27.23%, which was a 7.5% reduction in voluntary turnover under 1 year, which we estimate saved us about $1.4 million in turnover costs. So we are very proud of the work, the interdisciplinary work that we've done this year for both Tier 1 and Tier 2 goals. And now I will turn it over to Jill, who will start to share with you our AIP goals for 2024 and do the heavy lifting for 2025. You're welcome.
Thank you.
All right, good afternoon. I am first going to report out on where we landed for AIP for FY24. These were our metrics that we set last year after much discussion. First being all-cause readmissions. We did not achieve this. We ended the year at 11.9%. While we did not achieve this, we did a lot of work around our MVP, or multi-visit program, and so I'm very proud of the work that was led by Dr. Assad. We carried about 180 patients in that program, and we saw a readmission reduction from 30% readmission rate to 17%, which is significant for this population who was getting readmitted at least 4 times in a year. And so we know we still have work to do on that, and you'll see that later in our FY25 goals.
Board, the MVP program was something that Joint Commission in their survey was really, really impressed with. I mean, they were, like I said the other day, I mean, this woman, her face was like, 17%, I can't believe. I mean, it was kind of wild to see, so that's great.
Yeah, a lot of work by a lot of team members. They're the hardest ones to keep from readmitting, and so you really have to keep a close eye on them, have frequent touch points and outreach to keep them home, essentially. So, yeah, she did recognize that as a really phenomenal program and that we should be writing about it and telling our story. Depression response, this one we did, exceed stretch by a lot. Again, the team did do a great job of expanding from our depression response goal from the previous year for all patients. Previous year was for only behavioral health. This was across the network. And again, a lot like the MVP program, it really is about care navigation, case management, ensuring that patients who scored a high depression score had the services and resources they needed to lower that. Patient experience, we were barely over threshold. This was our greatest opportunity probably for next fiscal year, and I'll talk a little bit more about that. So we achieved just right at threshold. Employee engagement, you've already heard from Ashley. We did, I'll tell you, last year when we presented that goal and we had that number, we all as a team were like, oh my gosh, we did so great in FY23. This was going to be really tough. And our teams, I blew it out of the water. Again, 97th percentile rank as compared to our peers in that global database. And so did a great job at FY24. And so this is where we landed for the end of the year. Now I'm going to talk a little bit about FY25 goals. Background to kind of get us started. How do we develop our goals every year? The executive team, as well as additional team members, leaders, get together and we start talking about our goals and get input from them. Our data analytics team, they do help provide some metric recommendations. Again, they're looking at the statistical analysis, which might be a little different than what we're looking at from a threshold, target, and stretch. We also look at our external entities for benchmarking as well as data definitions as we're setting goals. Always our considerations for our goals really start with the strategic plan, and so we want to make sure our goals are aligned. Of course, we focus on our patients for their outcomes, our workforce for their engagement, and then overall financial sustainability for the district. We also look at, the involvement of all the network in our goals. Can they help drive these goals, or is it limited to certain departments? We want to make sure that they're, crossing across the network. And then it's a SMART goal. We want to make sure that it's specific, measurable, achievable, relevant, and it's time-bound. And then just as a reminder, all of our staff benefit from our AIP plan, which includes the individual contributors as well as our leaders. So where we landed for FY25, I'm really happy to present these goals to you. Again, we take input from last year. We finalize and incorporate those metrics, as well as looking at stretch and ensuring that we're really stretching our teams to do really great work. I've worked with many of the chairs of the different committees, Trent with the Finance Committee, worked with Dorothy from an HR perspective, also worked with Dr. Holland from a quality perspective, so they've had input into these goals as well. And so I feel like these are really good goals for our organization, for our patients, and for our team members. So patient experience, we are again going to look at overall rating bundle, and I'll describe each one of these in more detail in a minute. Team engagement, employee engagement will always be one of our goals. It's important for us to continue that engagement. Clinician engagement, we are adding back to our AIP scorecard. We think that's important to have the shared alignment between our staff and our clinicians. Quality goal, Dr. Batamosi has been here presenting on our Africa goal. It's I put the, what it stands for there, but essentially it's part of our CHIRP program in HHSC. And then financial, we heard last year we needed to include additional financial metrics, and so we've added some additional metrics, one being external funding, another one is operating margin, supplies per adjusted patient days, and then FTEs per adjusted patient days. Ashley today presented her Tier 2 goals. All of our committees will continue to present Tier 2. This is nowhere near all the goals or metrics that we track or follow, and so I just want you to know that we will continue to bring those Tier 2 present at the various committees. So patient experience, again, I want to touch on, we know we have opportunity here. When you look at our employee engagement scores, how they're not aligned with our patient experience scores is kind of a disconnect for us. And so Dorothy and I actually had some conversation earlier that I'm going to be taking back for future to think about, potentially this being a trigger for all staff to get the AIP plan, instituted. And so what is important about this particular goal is really it is all of our patient care areas. And so we know when patients have good experiences, it's not about being happy when you're here, but really do they have a good experience? We know there's a correlation with their patient care outcomes. We know that they listen to us more when they're engaged in their visit. They're going to listen to that advice. We know they also, will not utilize our resources unnecessarily because they're engaged, they know how to reach us, they know the questions to ask, and they're also listened to. So it's very important that we benchmark ourselves with this goal. Overall rating bundle is really great because it incorporates the entire system, so from surgery area to inpatient to our emergency department, behavioral health, and our outpatient areas. And there's national benchmarks out there related to inpatient experience and value-based care. CMS ratings are leapfrog, obviously overall brand and reputation, and it really is kind of the core of what we do, right, is taking good care of patients. And so what we would offer is our threshold be 75.6, our target 76, and the stretch is a stretch at 80. We have already really made this a priority for our teams, a dyad partnership led by Dr. Batamosi and Ashley Ridgway Washington to lead this work as forming a steering committee to ensure that we have some significant movement in patient experience this year.
Jill, questions. How is this measured? Is it a survey? And what's our current number for patient experience overall rating? And then what do these numbers mean, 75.6? I mean, where do those come from?
That's the rating. So all of our patients receive a survey, standardized survey from Press Ganey. They complete it. It's the standardized survey that you receive at most hospital systems. They score their survey based on their experience. They have their set questions, and this is the overall score that you get. So 75.6 is where we landed for a fiscal year 24. And then obviously target and stretch are, the metrics that we have to get better.
Jill, just for clarification, is this still, because I've kind of gotten out of the weeds as I've gotten higher up in the organization, are these the percentage of patients who give us top box?
It's top box.
Okay.
Yep,
So
9 or 10. So if you score an 8 on
overall,
something.
and-
Yep.
and
So if you.
it's- I'm sorry. But
And this is overall rating. And so they answer a number of questions about the care that they provide, but really it's the bottom question. Would you recommend this hospital? Would you recommend this, provider to your, to your family or friends? Overall rating.
And they have
Top
to mark
box.
a 9 or a 10.
Get credit.
Get credit.
And so 75.6% would have to give
9 or
us
10.
a 9 or a 10.
Exactly.
Okay.
So if you get an 8, you don't get anything.
Yeah.
credit.
Yeah.
That's important to know because, 75.6 in my world's a C. But that's 75.6 that marked us as an A or higher.
Yep. Top box score.
Okay, thank you.
75.5 this year.
It's 75.6.
5.6.
Yeah, we're saying leave it at,
75
Right.
Oh,
We're-
and 23.
We set it up a little bit higher.
For 24, fiscal year 24, we land at 75.4. So we're setting it higher for next year.
are we setting, it's the same, right? The threshold's where it ended?
No, we actually bumped it up
We
because we know
bumped
it's
it up.
important.
Okay, it was 75.6
6 this year,
this year.
75.5 last year.
Okay, but for the next year, the threshold is still 75.6.
A little bit higher than where we ended for '24,
Where did we end for 24 again?
75.5.
75.5.
0.5.
This is a matrix that we have been working on, and it's one of those that I believe that is critical for us to put emphasis on. It's also affect how we are paid and everything. This is one of those that I know we always have financial matrix triggers, but I think this is one of those that you probably need to look at having a clinical trigger. If we don't hit target, then I'm saying we're not going to move forward. You know, just like you have a financial one, if you don't hit that, you don't go, you get nothing. I think this is just as important. And so we've played with this, we keep working on it, but I don't think that everybody sees the significance. I will say it this way. For the employees, we have always had they've always been included in the plan, and we've given $500 or $700. But that was never tied into, we have to get this in order for you to get this. And I think we are ready to make that change, because unless every employee is committed to this, we're not going to move it.
What was the thing? We've been doing the patient bundle for a while now as far as metrics. What was 23 and 22 score? Because it's always been top box. That's always kind of.
It's always been top box,
Yeah.
yeah. The scoring's the same.
But is 24 higher than 23 and is 23 higher than 22?
We've overall kind of inched up.
Inched, yeah.
But to Dorothy's point, and we
You're thinking
have.
this will put it over the edge.
I do.
If it's a.
I think we've got to, and we have met as an executive team that there will be priority next year, just much like we've done with employee engagement now, and that's what you hear. We're going to now say we've got an engaged group of employees that should be able to get our patient experience starting to move. Usually what you see in organizations, as employee engagement goes up, patient experience starts to go up. Our patient experience has lagged behind employee engagement, and that's been for the 7 years that I've been here. So it's kind of unique in how this organization has not moved those two together. And so over this next year, we will be putting a lot of resource and effort behind getting patient experience caught up to our employee engagement. And so Dorothy is asking that the only way that you're probably going to be able to do this is to set some sort of trigger for the overall staff in order to receive this. I would ask that you allow us to put into place the foundation to get that work started, and we bring it back next year as a trigger, consideration for trigger.
I'm okay. I just want it on the table that needs to move. At the same time, I would ask for us to look at, if we are moving that, can we look at that base that where we've been paying $500 to the employee? Could that move a little bit too?
We could incentivize them instead of, it being a disincentive, that we could bump them up possibly 10, 20% if they are able to hit that stretch.
Yeah.
or target.
Because
So-
most hospitals have that patient satisfaction as one of their keys, and if the whole system doesn't get it, nobody get their little bonuses. So I'm just telling you.
Yeah, so I did bump up the weight on this.
Yeah, I'm glad to see that.
So that leadership now has more at stake. in the final payout.
Okay.
So if you can allow us to build that foundation.
I will allow you to build that foundation, but I want it known that that needs to change. You got a year to look at it and build a foundation, but we need to put more emphasis there. And I'm also saying we need to look at, if we are doing that for the employees, we've already, the executive, based on where they are, they get more, the employees should too. That's the other part of it, okay?
Dorothy, I think it's a great idea to make it a trigger or a threshold or whatever you call that. Can you explain a little bit? You said that this affects our reimbursement or the funds that come into the hospital. How does this score, I mean, if you have some detail, how does it affect, our payments that we receive?
Yeah, it does. So value-based care, they're looking not only at clinical metrics, but also patient experience for the same reasons I have listed above.
Want to come up?
Yeah, come here.
So when you're looking at value-based care contracts from payer agreements, they're looking at our scores as a quality metric to incentivize us to have higher scores, but it's because patients have better outcomes. As it relates to CMS and Leapfrog, Dr. Badamosi is going to share that.
Absolutely. So it's both reputational and financial impact. The regulatory part of it is our CMS star rating Leapfrog. It constitutes about 22% of each of those programs in terms of their reputational impact. And for Jill is exactly right. For the hospital value-based purchasing program, it's a big, significant part of that. And usually that's an extra 2 to 3% or a negative, depending on the performance as compared to other institutions nationwide.
And this particular scoring, what is this scoring system called that we're using for this patient experience overall rating bundle? Is there a name of the company?
Press-Ganey is the.
Press-Ganey?
Yeah, they're the ones who administer
Is
the
that universally
survey.
accepted by the value-based payers?
Yes.
Yes, sir.
Yeah. We have to use a certain vendor for CMS. CMS mandates who those authorized vendors are
You get a
to
choice.
administer that.
So this is accepted, and this would be a part of the overall score from the value-based payers? But they'd also look at Leapfrog and other things?
Yes, sir.
Absolutely.
Interesting, thank you.
It's a quality metric.
It all kind of ties together. Your quality goes up,
Yep.
patient experience goes up. As those goes up, the insurance and folks are paying you a little bit more based on that reputation that scoring that you're getting from your patient and what you're doing with quality. It's hand in hand, so.
We may be able to draw a better payer mix
Yeah.
now. Or showing our star rating, Leapfrog, where consumers go to look to see how well you're providing health care.
Okay,
And payers want to contract with you. I mean, that's part of it as well.
okay.
Thank you. All right, I'm going to move on to employee and clinician engagement. I think Ashley shared with you a lot of the reasons why it's important for us to have not only engaged employee workforce, but also adding back in our clinicians. I did add percentile rank when I'm showing the threshold, target, and stretch here because I want people to have perspective on, it's a 0 to 5, but achieving 5 is not really a thing when you're looking at, for example, employee engagement. To be in the 99th percentile, we would have had to score a 4.38. So there's very little movement from where we are right now, 4.32 to 4.38. So our team is wide-eyed when they looked at this goal for sure, because we all know maintaining excellence it's going to be a challenge. We know we have opportunities still with the clinicians, and so we did make some more stretch there to get to, at least to the 88th percentile for this next fiscal year.
And Jill, clinicians are currently at 4.13, was that where they finished?
They finished at 4.13, which is considered the 82nd percentile.
Okay, so that would then become the threshold for 25.
Exactly.
And how big of a deal is it to get them up to 4.24?
Well, that would be moving to the 88th percentile rank, so
That's a big one.
that's a big jump.
You're going to have to take them out to dinner. Take their calls.
This is going to be Blake school.
Whatever it takes, take one for the team.
Out some more pens, thank you. Any questions on employees and clinicians? All right, Africa. This is Dr. Mosi's bread and butter here. Again, this is part of the CHIRP program. He does review this in our quality committee. It's part of a bundle composite, which is really great for a quality metric for the organization because it's comprehensive across all sites of care. Not only women's, you have OR represented, outpatient, behavioral health, community health, you have inpatient, and also you'll see here all-cause readmission again, and so that gets layered back in. I will say what's unique about all-cause readmissions is previously, and really the CMS standard is around true inpatient admissions. The state decided to throw in observation admissions as well, and so this puts a new nuance to that particular metric. And so these are outcome-based. The top three are outcome-based. The bottom three are more process measures. We are doing well, pretty well so far, but we know, the higher amount of points that we get, the better it is for our patients. This is a huge financial metric for the organization. $18 million is on the hook for achieving this particular goal. And so we think this was a really great quality metric for us.
Jill, is the Africa payment 18 or nothing, or could it be anything in between?
So in order to get your 18 million, you have to achieve at least 9 points, but we know 9 points is great to achieve the 18 million, but we want to get higher than that because all of these relate to additional patient care outcomes and, quite frankly, dollars that are being spent.
And that's why this is not a financial goal, because we're setting the threshold over the 9 points.
It's a blend, I would say. It's a quality drives
quality.
finance.
We think it crosses both quality and financial, because we're going to bring in 18 million when this team hits.
Yeah.
But we get the
That's the
18 million at 9 points.
Right. And that's the hard financial incentive. There's additional financial incentives that you can't see, right? A lower C-section rate, it's cheaper to take care of a patient who doesn't have a C-section. And so you don't calculate all those costs. And, one post-op, sepsis case, you're talking thousands and thousands of dollars. And so all of these carry a financial component to them.
And of all the financial metrics, if this is considered a financial metric, of all the financial metrics we could use and this is for employees and clinicians, this is for both. Why do you pick this one? Why does this one have such significance compared to the others you could have chosen?
Because what I like about it the most is, again, it covers the entire hospital. And so you have women's working on their C-section rate. You have the peri-op area working on post-op surgeons, right? Their rate. All-cause readmission, boy, that's community health trying to make sure they have access in their clinics to take care of our patients so they don't come to the hospital sick and get readmitted. It includes our hospitalist group, again, for all-cause readmission because we want them to be discharged at the right time to be successful. We know the impact of flu immunizations. We don't want flu admissions. There's costs associated with that. So this really covers the entire network. If we just put up here C-section rate, which is a great metric, only women's is working to drive that. Flu immunization, man, you get flu shots in community health, in behavioral health, upon discharge from the hospital. And so this is a great quality metric for all of us to be all in for.
So it's going to impact this not only from a financial, and I think this point that Jill's making is that we're going to positively impact the outcomes of our patients in a way in which they're not utilizing our ED as much or taking up a hospital bed. So we are impacting our communities. At the same time, we can financially benefit, create some financial benefit for the organization. So I think it's a perfect goal in that sense.
I think our goal is to improve the health status of the folks that we serve, and it's just happened to be some payment attached to it. But our overall goal is to improve the health status of our patients, and all of these metrics that you are doing is measuring and showing how we are doing that, okay?
And I'd say it's kind of like patient experience too. Patient experience is a bundle, so it covers the entire network. This is a bundle, which is really nice that they put Africa like this.
Who scores Africa? Is that HHS?
HHSC.
Texas HHS? So it's a third party.
Yes.
And then tell me about the score. Is 15 like the top score? Is that a big hurdle?
18's the top score. You can get partial credit on some of these as well. The fortunate part is how the state designed this to achieve 18 is near impossible. It is actually impossible on some level because how they set their benchmarking. And remember, HHSC set 9 as the trigger to get the 18 million in our case, right? And so 18 was never a thing for them, for everyone to achieve 18. And so you got to keep that in mind, that we're kind of retrofitting into some of their scoring as well. For example, post-op sepsis, we're at 0 right now. So if we have 1, we get knocked out of that completely. And so it's going to be tough to get. Dr. Batamosi is back here sweating, I know, and he sees these numbers because, some of them were improvement over self, but some are benchmarks and you're already doing really well. And so it's hard to improve 0. So I know. Dr. Batamosi's working hard to help lead us through that too.
Is the bundle something that's come down from the Africa program, or are those quality measures ones that we picked out of a list
They're
that they
Africa's.
judge?
Yeah, they're
Okay.
Africa's. Yeah.
So everybody has these
They
same?
want us to focus on these as a state.
Okay,
No.
all right.
Yeah. Yeah.
And our score for the previous fiscal year was
What was it, Dr. Batamosi? 14.
14. So if it's 14, should we be setting our threshold at 12?
Dr. Batamosi?
One of the key things to understand about the Africa program is it resets. So all of the baseline that we currently have, all of the achievements we have last year become our new baseline. We have to beat those. I will give an example. If you use influenza immunization, for example, our achievement was around 86.47 or thereabout, and that becomes our new baseline. We have to beat that number to get that rate. For the all-cost readmission last year, the number to beat was 12.6. This year, the state has gone to 12.4. So there is really tightening of the program. The better your achievement, the harder it is to improve. That is hardwired into the program as it is. Jill did mention the issue of postoperative sepsis. We are 0. The biggest fear is getting even 1 case of postop sepsis, and that knocks us off. So all of these measures have inbuilt that you reset what your baseline, the number you have to beat, really changes based on your achievement.
So our baseline is based on our performance, not the average industry performance.
So for some of the benchmarks, the lower 3 are the improvement over self. The top 3 measures are the standard as set by the state, but with a mechanism in there to actually also make it much difficult. So I'll give another example. The cesarean section rate, the benchmark that was set by the state is 23.6. Achieve this and you get a full achievement. If a hospital A has an achievement of 23.5 last year, they achieved it. But going into next year, even though the benchmark is 23.6, the number to beat is that 23.5 because that is their new benchmark to have full achievement. So every single of those measures are inbuilt that way. And when a lot of hospitals, including us, we were worried about this and actually engaged with the state, and the state was, yes, this is exactly the way we designed it, and this is the way we want it to be. We want the better you are, the harder is it to improve.
Because let me see if I can repeat that. So there's 6 measures here. The first 3, which are C-section, post-op sepsis, and readmission rates, those are state averages, but the next 3 are based on our prior years?
Correct.
So we have to make improvement. We're competing against ourselves on the second 3. We've got to beat our last year's scores.
We got to beat our last year's score. And for the top 3, we have to beat our last year's score as well. Yes, because
It's both.
It's both. So for cesarean section, if we take that as 23.6 is a state benchmark, they say, okay, all hospital, this is what you gotta hit. Get your cesarean section rate to 23.6. If we hit that, we achieve it. Let's assume we hit it at 23.5. So we achieve it. But next year, they've put it out again, hit 23.6. But for those of you that did beat it last year at 23.5, your new benchmark is 23.5.
So it's the lower of,
Yes, it's the
Lower
lower
of
of the, correct.
and the second three don't have a state setting?
It's improvement over self.
Okay, so it's only, okay, and so the top three are harder to meet because you got to meet two standards.
Very hard.
Okay, very interesting.
And I would argue even the bottom
You gotta
are.
beat yourself.
Came in at it doing really well, then there's not much room to work with, right? If we were doing really poor, then we could only go up.
Yes.
But if you're already doing really well with something, it makes it that much difficult. And that's what they were saying. They were 0 at post-op sepsis, so all it takes is just 1. And just think of the 1.2 million visits that we kind of run through here.
Oh, my gosh.
Well, and I would also say, like influenza, for example, improvement over self, we already had a really high, flu rate, or flu immunization rate. And so improvement over self is work, because we already did really well at that, so.
Compared to Texas average, we're consistently less than 50% vaccination for influenza. Our JPS for this population that we're looking at, we're at about 86%. So for next year, that resets our baseline. We have to beat that number to achieve the 2 points for that metrics.
Do you think, Dr. Batamosa, do you think that 12 as a threshold and 13 as a target are challenging enough for our employees?
Yes.
Or should they be raised maybe by 1 each?
Very challenging.
Even though we had a 14 last year?
Yes, and I can explain a little bit more. If you look at all-cause readmission, nationally, the average for CMS is about 14.4. That is the average. The lowest state is Hawaii at 13.5. HHS is set there at 12.4. And it's not just all-cause 30-day readmission to the hospital, it includes OBS. If you put those with OBS, the average number is around 19-20% nationwide. So there's already a shortfall of about 8 points. It's extremely difficult to achieve that. So that really lowers everybody's point, all hospitals participating in this program, as a practical matter, to a cap of 14, because it's so difficult to achieve.
You mentioned other states like Hawaii. Is Africa used in all states, or is it
No,
just Texas?
this is Texas.
But they
I
have
just
something.
gave national benchmark numbers, yes.
Okay. Since it's only, you need a 9 to get the $18 million payment, what other accolades or value do we get from higher scores? Or maybe with third-party payers, do they pay us more if we have a higher Africa? Do they take that? Do the value-based payers?
I think the biggest, yes, it really impacts a lot of what we do because, again, 30-day readmission is also a CMS measure. Post-op sepsis rate is part of the PSI 90 that factors into harm that we also look at. And
Would be there, yeah.
yeah, so it really cuts across a whole lot of other safety programs and measures and quality measures. And even more importantly, to Jill's earlier point, building a system and hardwiring a system to actually consistently ensure that we improve all of these metrics, I think is the biggest achievement here. Because when we develop this system, we're not just targeting the population that we are reporting to the state. We target all comers. Any idea, any process improvement that we're developing, we are hardwiring it as we go along so that it will be enduring to ensure we have continued and consistent improvement in all of these measures.
Thank you.
Yes.
You okay?
I'm great.
I think it's a good one. I mean, it's the best one. Yeah.
Okay. All right, we'll move on. Getting into some financial metrics. This is the external funding bundle. So we were looking at ways to really look at additional revenue streams. And so these, again, it's kind of a bundle for us, looking at increasing our grant applications and awards, increasing our clinical trials, increasing our foundation fundraising, and finally, increasing our governmental funding programs. And so again, this is an opportunity for us to generate revenue for cost savings as well as diversification of our funding sources. The other great thing about this is it brings in all those additional departments like our foundation, like our government affairs office, grants and research office to get additional money into our system. And so our baseline for FY24 with all those activities brought in $27.6 million. So we're looking to increase that 13% for target, 14% for stretch. So essentially looking at an increase of 3.6 million for target and 3.9 for stretch.
And your reason for starting it low was that we were just not getting the foundation set. It's going to take us a chance to get that set up. I even think on some of those clinical trials we are not as advanced as we used to be on those. So it's
Some opportunity there.
next year you're going to have to look at those foundations and make sure those are in place. And then the next year you would be looking at saying, yeah, we can increase that number.
And we're
Okay?
also going into a new state legislature this year, and so we think there's opportunities, much like we saw in the last legislative process around the LCA beds and increasing those dollar amounts. We're looking for things like that, and so that's really what the governmental funding programs, that's an example of that.
Is the foundation fundraising any and all type of foundation fundraising, whether it be capital for the bond project, whether it be for a new robot, whether it be employee giving?
It's all.
It's all.
It's all in, yeah.
Anything over what it costs them to run the foundation. So it'd
Okay.
be over expenses, yeah.
Yep.
Revenue over expenses.
Jill, I think that the stretch should be a little more stretch from the target. Those are, numbers are on top of each other. Do you have a strong opinion about 31.5?
Again, I think, back to the point around the foundation, I think there's opportunity there, and we know bringing Leah on board. We also know Leah has a ramp-up period with her team to get the foundation really moving and going, and so I think we felt like 13% was already going to be a nice increase for us, and then we chose 14% as an additional amount.
I don't disagree with you, Blake, but I think maybe next year that gap widens. I think with the first year, I mean, let's face it,
Gotta build
this is
it.
year one of the foundation. I mean, with,
Where would you like to see it, Lloyd?
Do we have the numbers here today for each of these 4 components, what they were in fiscal year? If not, can I get them later?
Yeah, I can definitely get
Because
those to
these
you.
4 components added up 27.6, so I guess
They do.
somewhere we have the numbers.
Right.
The 27.6 is all of it combined. That was our baseline, so that's where we ended for FY24.
Governmental funding programs, that's everything around here, but it's obviously, what programs are those?
So I'll give you the example. Last legislature, Zelia and Ashley worked at the state level to increase our funding for our LCA, our long-term commitment alternative beds. And so that's that kind of funding.
Okay.
There's some community grants that are out there too that can be brought in.
I think we need to define that in our AIP, so everybody, it's on the table.
Knows what that
everybody knows.
category is.
Yeah, because
Yeah.
I mean, I don't know what they are, but it's clearly, given the money involved, these aren't these huge programs that pay us most of
Right.
our money. These are smaller things. But if we could itemize those so that there's no disagreement when we're measuring it.
How we're measuring it.
Yeah,
Yes.
and then we could talk later about what they are. And if I could get the numbers for each of these for 24, I'd like to have them, we can talk later.
Okay. Any other questions on that one?
how do we or would we score cost savings and diversification, and, or is that
Cost
just?
savings really in those clinical trials, so they help support the drugs or, the medicines that take care of our patients. So that's really the cost savings component. And so you would look at what dollars are you getting from those trials, and that would contribute to this number.
Okay.
There should be some lab tests that we don't pay
Yeah,
for.
things that are
We
covered by
paid
the
to do
trial.
them, So
Transportation, things like that.
Okay. And then, so diversification, I mean, how do you show year-over-year improvement over diversification of funding sources?
It would be the increase in this overall amount.
Okay.
Yeah.
But I think the board's going to have to sit down and have a discussion on, looking at where we should focus on that diversity
Yeah.
of funds. Okay.
I think it's more kind of that non-traditional way in which have funded our needs, and foundation has not been one of those. And so
Right.
we would see this now as new kind of funding coming
Yeah.
in.
I mean, I'm indifferent on this first year, but I do think, I mean, especially when we really get into raising money for the bond program, the master facilities plan, a single gift could be $25 million. It may not be this year, and maybe not next year, but as that
build it.
plan comes, gets a little more hardcore.
No, Leah's not in here, but yeah, I agree with you.
Yeah.
It's just a matter of her getting,
Sure.
that foundation set up to do what I think she can do, so I agree with you.
Ashley, our chair just said he's indifferent. Can you try to get him up to the
Sorry, I need training.
be engaged level? Because he's in the yellow, he needs to be in the green.
Now we know what.
All right, we'll move into some additional financial metrics. This was operating margin, so we know this is an important metric, industry standard metric, overall financial health for our district. We know we need this excess margin to create additional cash flow for future fund. We also know that we need to maintain our minimum bond rating at Moody's median or better. So threshold is where our budget is set, which is 2.1%. Target 2.9%, that really equates to around $14 million, which is where that tax rate decrease kind of put us at there at the end of our budgeting process. And then stretch would be that further tax rate plus homestead exemption, which was $34 million. And so that's how those were set.
And these may be Jill or Rory questions, but fiscal year '24, however you're measuring this number, was it 2.1?
2.1 is where the budget is set to maintain our bond rating.
2.1 is our budget for
FY
25.
'25, yes.
Okay. And then if I'm looking at our income statement, this may be a Rory question, how do I measure this?
The operating margin, how do you measure it?
Yes, I mean, because we're including property tax, or, I mean, you can measure this different ways.
Yeah, so there's a calculation on the face of the income statement or in the Tier 2 scorecard that has the operating margin, I believe.
Okay.
It would be everything but non-operational things such as investments. So you would exclude investments, you would exclude real estate transactions, things like that. So it's truly an operational measure. And so patient revenues minus your operating expenses.
Okay, and it's positive because you're including property tax?
That's correct. That is correct.
Okay. So to get from 2.1 to 4, I mean, just an increase in appraisals alone could help that grow, if you know, or a cut in the tax rate could make that shrink.
That's correct.
Correct.
So this is subject to external forces beyond which we have no control.
Yeah.
Internal
Supplemental
and
funding.
There's
yes,
internal
all that.
too.
internal and external, certainly. But the mindset was, the ask has been, let's try to be less reliant on the tax dollars. So thinking through how to reach back out and reclaim some of that revenue or reduce expense, it would put us kind of back on a similar level as where we were. So we went from 1925 to 1875 and then down to 1825 from a rate perspective. That's how you get back to the 4% margin. I still say that 4 is extremely challenging in our current year. Couple of things. We significantly squeezed the budget with respect to accuracy. If you look at the margin for '24 compared to what we've set for next year, we've squeezed out a lot of that excess. And you'll see that reflected in our October financials. If you were to annualize that first month, it's darn close to that 2.1, really. So we're going to have to work hard to find an additional 2% to get from 2 to 4.
Okay. And this is easy for you to measure?
Very. It's standard, industry standard, yes.
I like this as a beginning step. We may refine it for the next year, but if it's easy to measure and it's requiring us to try to improve our numbers. Now, some of this could be, blessing from heaven that we get an extra $50 million we weren't expecting.
It is possible.
You know, and Trent and I came up with a plan that we need to develop more with you for a future year that's trying to exclude these third-party sources of funding. So we're more identifying improvement in our finances that we can control internally. But those would obviously be much harder to track because there's going to be more moving parts. I think this is, you know, for a starting point, this is a pretty good start.
I think you hit the nail on the head when you said hard to track and also somewhat punitive if you're establishing a significant chunk of a plan on something that's unproven and certainly not industry standard to measure that reliance or that non-tax related operating income. That's just not an industry norm, and that would be something we'd be creating very outside of a normal hospital environment.
Yeah,
I understand.
agree. And Blake, the other thing, I know, you know, we say, hey, we can get a gift from supplemental. Understand how hard this team works at the state level in order to find out where there's opportunity to pull more money in. So it's not just that we wake up one day and somebody says, oh, you got another 50 million. We are working alongside other public-like hospitals across Texas to figure out kind of how we can close the gap on that uncompensated care. So it's never a gift, it's really a lot of work that we do. So we're not just here, but we're at the state, and then we also have to navigate the local. So I just want to throw that out. That takes a lot of work.
To answer your, I'm sorry, go ahead. So I think also to answer your question about this one, the next two goals really help support the operations to reduce expenses or look expenses more closely. This is completely what we have control over.
And I just got to say, everybody in this room and every board member that sits around this table have to keep in mind that the importance of that 2.1 number, maintaining that bond rating, or all this stuff gets way more expensive. I mean, it's, and the Commissioners Court needs to understand that. That 180 days and that 2.1, those are critical numbers that we have to operate on.
Yeah, I would say it's probably even more than that, and Rory can probably weigh in on it. But we will really have to defend those tax cuts when we sit before those bond rating. Even though we've had a good financial year, they are going to be concerned about future years. And so it is going to be a tough conversation. Rory, would you admit?
I think most definitely when you start, they look for stability in your financial operations, and certainly those kind of decreases don't create stability. And that's one of the key factors in bond ratings is stable outlook.
And Rory, is 2.1% operating margin, as you're measuring it, is that the minimum to maintain our current rating?
It's the Moody's minimum, it's the median, so.
Median?
Median, correct, not minimum. I almost said minimum, but it's the median.
So if we went to 2.0, does that break the rating?
No, not likely. It's one factor. They really look, as Roger mentioned, on also days cash on hand is very important. And then, of course, stable revenues would be the ones that they're really focused on.
So we could keep the same bond rating, but we could be rated as being unstable. Is it what's the term they use?
Yeah, there's a stable outlook, which you're referring to.
Stable outlook, yeah.
You
So
might
they
not
could-
get that.
Yeah, we may not get that, yeah.
All right, two additional financial metrics. This is around supply costs per adjusted patient days. Again, supply cost correlate with financial stability of the organization. This is a good metric because it crosses all parts of the organization. Some additional information, though, because we are, having headwinds with continued increased costs related to supplies as well as opening of these new sites. So this includes medical supplies, office supplies, IT, instruments, linen, bedding, anything you can think of, not capital, but really those supply costs to take care of our patients or, our different areas. So threshold we set at 324.04 to do target, which would be a $2.77 million reduction, and at 317.56, and then stretch would be 30784, which would be a $6.92 million decrease. We know we have some opportunity here. Again, we're focusing some efforts this year around supply cost, bringing in a new leader around supply chain, and so this will be a big focus for the organization for this upcoming year.
Rory, where would you say our biggest opportunity would be in the OR?
Yeah, procedural areas, implants,
Yeah.
but also just around standardization
Yeah.
of product and just also not just standardization, but utilization. We've seen through some recent challenges with IV fluids that there's opportunity for us to look at utilization and reduce costs just through utilization as well.
Yeah, so this is a good one because it is across the organization. It's going to take changes in our physicians. We're going to need them on board along with our team members. So I think this is a great one that we've not looked at before, and it also requires us to really up our supply chain processes and opportunities.
There's also a concern that we don't get so caught up in it that we start having some patient care issues. You know how folks want to save money and get into that.
Which is why we made this a goal for the executives.
Why we made it executives only.
Oh, okay.
Yeah, so,
Yeah.
Well,
To try to
I
help,
won't say it again.
try to help
I
eliminate that.
understand that, but I just want us to realize that sometimes when you get caught up in that some things start slipping. You know, I've been here long enough to know that we had instruments we should have got rid of a long time ago. I don't want that to happen again, you know.
yeah, so I hear you, because I think we also had the concern with facilities, right, and savings on that. What we look at, Dorothy, is where our opportunity is each year. I think at some point, we are going to squeeze out all that we can with supply chain, and this one should drop off at that point. So we do see that there's some opportunity, at least a $3 million opportunity.
I do see that you can. You know, we've had this cost before, it just went up. Where you started, you kept going up the next year.
Jill, on this, do you know what our fiscal year '24 number would have been? Or Rory?
I don't have it in front of me, but you would need to really look at inflation as a factor in that. So you can't, you would not set the threshold at last year because of inflation running 5 to 8% in supply items. So it's very hard to say we're going to be at
Is it
threshold.
300 or higher, or do you have any?
2404 is what we set for the budget, though, for
Yes.
fiscal year.
Oh, that was our
That's the
budget?
for-
That's our
Okay.
budget.
Yeah, and so that considered those inflationary costs.
So, and I don't have the budget in front of me, but I reverse engineered the math. So we're spending about $156 million on supplies in a year. Does that sound right?
It probably wouldn't be that far off. I don't have the income statement in front of me, but that's probably, I think I recall 130 to 150. I'd have to look.
Okay.
We could go back to the non-23 or non-30 financials and look.
I mean, and this can be done later with some of these other numbers. Can I find out what the fiscal year '24 was final?
It'll obviously be lower than the 324 because of the inflation. You could probably knock off somewhere around, like I said, 5 to 8%, but I can get you an exact number. That's not a
Okay,
problem.
thanks.
And then the last financial metric is around FTEs per adjusted patient day. And so again, this is some work that we're going to be doing this year around labor management council, labor management strategies. To Dorothy's point earlier, you have to be careful about this because you still have to have the right amount of people taking care of our patients, but we do think there's some opportunity. We also will be bringing on board our Strata real-time productivity tool, which will allow our leaders to make real-time, staffing decisions during the shift with those variable staff as well. So we know we have some opportunity here, again, with some low-hanging fruit. Threshold, again, 5.88, that's our budget. Target, 5.84, which would be about a $4 million pickup based on FTEs. And then 5.79 would be about an $8 million pickup.
Okay.
This would be the summary document. So this would be for our staff and leaders. Dr. Duncan mentioned a heavy weight on patient experience, so 30% for our teams. Team engagement, clinician and employee engagement, 20%. The quality metric for Africa, 30%, heavy weight on that one, as well as our financial bundle, external funding bundle at 20%. Our executives would have a different tiered scorecard, patient experience still a heavy weight of 30%, team engagement 10%, quality, Africa 20%, and then financial will be 40%. Again, a big heavy weight on the financial metrics for the executive team.
Jill, just a couple of comments about the overall process. First, I think you and your team have done a really good job, creative, coming up with some of these financial incentives and the quality incentives too. I'm the one that's been pressing for, financial metrics to keep everybody focused on our bottom line while taking care of our patients and pushing forward our mission, which, by the way, with engagement, Ashley, I mean, one thing we have going for us at JPS that other hospitals don't is our mission. And a lot of people I hope everybody that works here is a strong believer in our mission. You may not like your boss every day, but you can believe in our mission every single day. But I think you've done a great job here. I don't think I'd thought about having a different set of metrics for the executives than the rest of the employees, but I think that's very appropriate also.
Yep.
So compliment you on that. I'm going to be in favor of all that you've recommended here. I will say I may, after getting some numbers, suggest tweaks at the board meeting, so don't be surprised if I make some suggestions that are just small adjustments, but I think this is an excellent plan you put together.
Thank you.
Yeah, thank you, Blake. I truly appreciate, because this team has really worked hard. They do listen to what the board is saying and the direction that the board wants to go towards. And so I do want to commend the team. They have worked long. They have been told to stretch and get, to be able to move maybe a little further and a little quicker, and they've taken on that challenge. And so I do want to commend all of them for not jumping ship after we put these together, so.
Joint Commission.
Yeah, that patient experience bundle, it was like where it was, and I said, well, 80, and they went, 80?
Yeah, she came in and she turned it and she said, Dorothy said this one's going to go to 80. And I think she thought I was going to say, oh, no, I'm going to fight that one. And I said, okay, I actually think we can go a little bit higher. And she was like, oh, forget it. Thank you so much, Jill.
Thank you, Jill.
Huge work.
Thank you, great job. Okay. Ashley, you're back up with the, oh, wait a minute, okay. Sorry. So first of all, we have the approval of the fiscal year 25 AIP goals.
I move to approve them as presented.
Okay. I'll second. All right, it's been motion second. All those in favor signify by saying aye. Aye. It's three of us, so okay, it's approved.
Small but mighty.
Okay, all right, then I'm ready for Ashley, all right. Thank you, Jill. See, I told you it wasn't going to be hard.
One procedure before you, policy. I don't know why I can't get that straight today. One policy before you. Not very many substantive changes. I believe the red line was included in the portal, and the updates are essentially that we updated the procedure to clarify that talent acquisition is the process owner for our reference and background checks, and then it also revises to language to clarify a bit that new hires and transfers are required to complete their post-offer background screen and occupational health screening prior to their start date.
Okay. Anyone have any questions on that?
No, the red lines were self-explanatory.
Okay. So, there being no other discussion, all those in favor of approving HR 500 reference?
We need a motion, I guess, technically.
Yeah, that's what I'm finna ask for.
Okay.
So moved.
Second.
All right, it's been motion and second before I could even ask for it, but thank you. All those of you signify approval by saying aye.
Aye.
Motion passes, okay? All right, we did not have anything for closed session, right? All right, listen, gang, thank y'all. You did an awesome job. Appreciate it, okay? All right, there being no further business, we are adjourned, okay?